shack and I aren't impressed by the cardiomegaly, but the echo may give you a better idea about the volume load.
Okay.
There is, the EKG, definitely there is LVH by voltage.
Yeah, sure.
Okay. Now we can show online fluoro. Yeah, just can you widen the this one? Widen the whole. Make the table come up. Show the entire heart. Don't zoom on the heart. We want to see the entire chest. Zero mag. Zero mag. Neil, you had a concern about the heart being too small. No, go out fully.
No, it's cardiomegaly.
Yeah. Okay. Now show the echo. Echo the PowerPoint. Get back the PowerPoint. Echo. So this was a perimembranous ventricular septal defect with a significant septal aneurysm. Next. And you can appreciate that there are actually two jets. Dr. Srija will explain the echocardiography recorded views. Next picture. So this was a moderate sized perimembranous VSD with left atrium, left ventricular volume overload. Srija, can you show? Actually, we recorded some images.
There are some images.
Okay. So this was the.
They have to show the echo.
I think Srija did not see it at all. Can you go and show?
Yeah.
You can go and show, because actually Dr. Ramya did the echocardiography. Bhushan, can you keep moving the live echoes? There were a frame where there were two holes.
Yes, sir.
Yeah, that's it.
That's the previous one.
Previous one. So this is basically the septal aneurysm. Now we will show it live. Show the next picture.
Next picture.
Yeah, next picture. Yeah, those are the two orifices, and then on the echocardiogram you will identify that the two orifices will light up with color. Next.
Next.
Ramya, freeze it and show the two orifices, Ramya. Yeah, just no, you have to slowly go back and forth. Keep moving up and down. You can show that there are two. Yes. Keep going further. Yeah, you can now color suppress.
Color. So see, this is a pretty big hole.
Yeah. So there was a septal aneurysm with two exit orifices, and both of them measured about, one was 5 and one was 4. When we were doing the transthoracic echocardiography, we felt that it was something like an 8 millimeter, a single orifice. However, the TE showed that you can appreciate here. Ramya, make it bigger so that they zoom on that. You freeze the frame where you can appreciate the two jets.
So is your plan to use one device here or multiple devices?
No, I'm actually planning, since it is an aneurysmal tissue, planning to put one single device. However, not like you see that there are two orifices, one smaller orifice superiorly and one larger orifice inferiorly. We thought that we will be pushing the two together, like how we tackle like atrial septum, septal defects which are closer to each other. Can you go to LAO? So then show the LV angiogram. Ramya, what was the pulmonary artery pressures?
30 systolic with a mean of 20.
Okay. Dr. Ramya says that the pulmonary artery, you are wired, you can speak out. The pulmonary artery systolic pressure was 30 with a mean of 20, and the aortic pressures were around 90 systolic. So this was the left. Yes.
This is Varakan.
Yes.
I think to me, from the angio and also echo, it looks quite complicated one, or multiple axes, and it's aneurysmal type defect, and it's not small.
Okay.
So it's going to be challenging. Yeah. So the plan again, if I understand correctly, you're going to put one device, right?
Yes.
What kind of device you plan to use?
Since actually the left ventricular entry of the, come to AP view, since the left ventricular entry of the hole was measuring quite large, about 15 millimeter, and the two final exits were 5 and 4, we were planning to put in like 8 millimeter Occlutech perimembranous VSD device after taking a circuit. The 8 millimeter will have a 16 millimeter LV disc, which should be able to cover the entire track. What is your thought?
Sivakumar, just a question.
Yes.
What was the RP pressure you said?
30.
30.
30. Yeah. So can you come down?
And the PA pressure?
The PA pressure was 30. PA pressure was 30
so
systolic. You can get back the recording.
Show the PA pressure recording.
Can you show the
Occlutech device?
Yes.
3 millimeter. Okay. Well, Supa say yes. The lady is in the house. Say yes.
Okay, good. I think Supa has got probably more experience with occlutech devices. Can you show me the? So I have got the wire advanced into the inferior vena cava. So I'm trying to snare it. Let me see whether it is caught. Yeah, it is caught. So I'm going to catch the last part of the wire.
Siva,
Okay.
can we see the fluoro or the echo?
Yeah.
We don't need, yeah.
Can you show me the
Thank you.
top? So there is a small loop. Let me see whether we are able to open out that loop now.
You happy with that loop, Shiva?
Yeah. No, I'm going to relax on the loop. Let me see whether it opens out.
Okay.
I think the catheter was holding it. Now I'm going to take the 8 millimeter occlutech perimembranous VSD device goes through. Can you give me a clamp?
Sheath. Get me the sheath.
Goes through 7 French. Wait.
So what sheet you going to use?
We,
The model or
we are planning to
Yeah.
use no, we are actually we normally use the Cook sheets, or we can use the braided sheets of Occlutech. Right now I'm going to be using a braided sheet. So you can
and you plan to deploy from the aorta, am I correct?
no I'm going to deploy it from the left ventricle. I'll show you how I'm going to twist
Okay.
my catheter. So
Yeah.
I want a 4 French pigtail.
Any particular reason on that you plan to go from the deploy from the left ventricle?
Unlike an ADO1 device, which will have for example, the LV disc will be a little smaller, whereas in an Occlutech 8 millimeter perimembranous VSD device, it is 16 millimeter. So since it is 16 millimeter, a flat disc, I don't want it to be pulled through the aortic valve.
Okay,
What
got
what is your thought process?
Well, depends on how do you feel comfortable
want
with
another clamp.
where you're gonna put the device. Open the device. Whatever you're happy, just go for that.
You'll be happy to pull it through the aortic valve, or what's your thought?
Well, it's better to go for the LV definitely.
Okay. So now I want a 4 French pigtail catheter. So I'm 4 French pigtail catheter. Go back to that LAO. So what I do is I connect the tip of my sheath on pressure.
Would you mind just pull back the TE up a bit?
Yeah,
so we can see
Srija, the TE can
how
go
you're
up.
pushing everything into the left ventricle, so then we can see clearly.
Yeah. So what I have done is I have connected the tip of my sheath. Srija, a little bit more. Out. I want Mohammed. Can you go to LAO wire in?
Wire, normal wire. Get
I
me
want a J wire.
Wire.
I want a J thermo wire. That's a
Not
straight thermo.
no,
I want a J thermo. No,
J.
give another J thermo wire. So the intention will be, see, right now the catheter is in the ascending aorta. So
Get
what
the
we'll
J.
be doing will be, I will open out the pigtail in the ascending aorta.
J,
I will
J.
keep on slowly coming down and get the pigtail towards the left ventricular outflow tract, advance a thermo wire, and once that thermo wire, just can you hold the wire?
Yes. I'll exchange it to a J. This is a straight.
Okay.
Get me the J.
Okay, let it be there till I
It's a
come out.
straight. It's a
Yeah,
straight.
that's okay. Till we
Out. Yeah.
let the catheter come out. Yeah, the catheter has come far.
Yeah. I'll take
Okay.
this out. Get me the J, please.
Leave it. So at this point, I am going to be taking a J thermo wire. As I am slipping from the aorta into the left ventricle briefly, so right now I am in the aorta still. I'll keep my wire ready at the tip. Okay, and then Srija, Ramya, come here. Little bit, can you pull? Yeah, we are getting into the left ventricular outflow tract now. Little bit pull. Yes. Okay. So now I want it to fall into the left ventricle, and once it falls into the left ventricle, I will advance my pigtail catheter deep into the left ventricle. so that it gives me the support. Yes, and now I will try to take out the other guide wire, which was okay. So right now this pigtail catheter is quite well placed in the. Can you give me an amplat superstiff guide wire now? Yes, sir. So I will try to.
Siva,
Yep.
why do you do that? Have you had a bad experience delivering devices coming back through the aortic valve?
This particular device of Occlutech perimembranous VSD device has got a little larger LV disc. It is 4 mm larger on either sides. So an 8 mm Occlutech perimembranous VSD has got a 16 mm flat disc, and the entire disc will open out in the ascending aorta. And I'm a little worried about 16 mm disc, flat disc coming through.
I understand that.
Shaq is, I think Shiva is absolutely right, because the disc is not only largish, but it's also a bit stiffer. And so you don't want to be pulling something like that through the aortic valve. But the way Shiva is demonstrating this sheath positioning in the left ventricle with the pigtail moved along, I think if this works, then it's a fantastic way of doing it.
Indeed.
But I wouldn't have broken the circuit until the sheath remained in, because it came back a bit too much, and I would have kept it in the left ventricular outflow tract and pushed it down there.
It looks like you're struggling to get across into the left ventricle with your long sheath over that pigtail, Shiva. Is that the?
Correct. Actually, what is happening is my guide wire has got a very short floppy tip. So I might put in sometimes a shaped dilator. Let me see whether I'm walking in.
Mansoor here.
Yes.
Siva,
Yes.
don't you think if you come from the aortic side and with your sheath, everything from the aortic side without doing all these hassle, won't make it a shorter procedure?
Okay.
Probably do this.
You are talking about retrograde delivery of the Occlutech. Yeah. Yesterday Kevin Walsh was demonstrating one, but we need to understand that the larger LV disc will be on the RV side and the smaller RV disc will be on the LV side. Will you be happy about it?
Well, no.
It's not a symmetric device. It has got a 2 mm protrusion on the.
But this is the beauty if you have a multiple device in a cath lab. For example, an Amblatzer device will do very good job in this patient from retrograde.
Possible. Correct. Actually, then for an 8 mm Amblatzer also would have been a possibility. I'm just trying to get it. If it is not crossing, let me see here. Okay, I will take the other suggestion.
Between the pigtail and the sheath.
Hang up the tip of the sheath, the aneurysm of the VS.
Yeah.
That's why I would exchange the pigtail and put the dilator of the sheath.
Yes, I'll do that. I'm doing that, Z. Now, so can I have the dilator? I want to pre-shape the dilator into a curve. Can you?
I'm holding.
Yeah. Where is the dilator?
One.
No, this dilator.
Dilator of
This
the sheath.
LifeTex dilator that we took out.
Dilator of the sheath.
The dilator that we took out.
Shifted up. Why don't you take it?
I have a question.
Or one
Yes. We are just finding out where the dilator is. So, can you?
Where is the dilator?
Shiva,
Yes.
I have a question
Yes, please.
to check whether you pass the smaller one or the larger hole
Get that one.
with this wire.
It's possible. It's possible, Z. Actually, Srija, can you try to find out? Can you try to find out whether it is going through the superior orifice?
So that's why you come across.
Dilator is
sheath
there.
here.
Dilator is there.
It's going to be.
But did you get that?
The
question from the audience whether we cross the smaller hole rather than the big one, so that's why the sheath cannot get into the defect.
Actually, Srija is trying to look at it because we pulled out the transesophageal echo probe for a better fluoroscopy short while ago. Yeah, hold it.
Straight.
Hold
Keep it straight. And
Hold. I'm trying with the dilator. Basically, we should not have this. Hold it here, sister.
I'll come.
looks like there is a weakness in this technique, Shaq.
Well, the technique is good, but I think it's really where the sheath came back too much through the aneurysm.
Can you give me a 6
at
French
the
guide
time of
catheter?
trying-
6 French guide catheter.
At the time of trying to get the
Okay, hold it.
pigtail down,
Yeah.
the sheath has to remain in the aortic valve position
Yeah.
before you break the circuit.
Shaq, one of the problem that I'm getting with the dilator is that the dilator was too rigid. So I'm trying to use a coronary guide
Take this out,
catheter
take this out.
and use the guide catheter as my dilator. Let me see whether that works. So I'm yes.
Is it possible to just put
So
the
the
wire a
superior
little
or
bit up to
bigger one?
ascending or descending aorta? Because I've learned from Indonesian doctors, that's very nice. Because once the wire is more distal to the descending aorta, now you get better chance to get to the the LV. Because that part probably is a little bit dark.
I agree.
Maybe you can just snare it from the aortic side. Snare the wire, pull it back, the whole sheet back to the ascending aorta.
No, the sheath was actually going into the ascending aorta easily. I wanted it into the left ventricle.
LV.
So, so right now I am using the guide catheter. Okay, so we have got the sheath inside. So right now, what we are planning to do will be take. Our original plan was 8 millimeter perimembranous ventricular septal. I'm trying to clear out.
How is the EKG, just for interest sake? The
Okay.
EKG looks good.
The ECG is showing a lot of ventricular ectopics, so I am trying to slowly adjust my catheter, the sheath position. You see, it is hitting against the lateral wall of the left ventricle. Can you show the ECG? It's showing a lot of ventricular ectopics, but the blood pressure is the LV pressure is remaining stable. I have connected to the left ventricle. Can you put this on the aorta?
Shiva,
Yes.
this is an important point, isn't it? Because that sheath is now fairly sharp tip
Yes.
and is
I'm
beating the posterior wall, and so you have to really be very careful or pull it back into the cavity.
I'm doing that, Shaq. As I'm talking to you, I'm slowly withdrawing it, just to ensure that I don't totally come out. This time maybe I'm touching the mitral valve. I'll do one thing. The moment I have my device inside, then I'll have a little bit more comfort. The blood pressure is stable, even though there are plenty of ventricular ectopics. Can you open the device, please? 8 millimeter perimembranous occlutech. Yep. Open the. Again, as was shown in the previous, this is also a flex design, which means the device will align itself. So this is the blue pusher.
Shiva,
Yes.
do you do, as just a quick check, angiogram at all through the sheath, just to make sure it's not against any other structures?
So can you now see that the ECG is getting stabilized? Can you show the ECG now live?
ECG.
ECG is getting stabilized now. I think it will be stable.
Shiva, did you get a question that Jack asked? Whether or not should we do repeated LV angio now, just to check for everything before we decide the device, the size, whatever.
Okay, sure. I'll do that. Okay, so now I will. Is this the pigtail that is there in the
No, this is the RCA.
right coronary? Okay. Can we have a pigtail catheter in the left ventricle now? The rhythm is stable
Get the
now.
pigtail with the wire.
With a wire?
Get pigtail with
You
wire
can
is
do
here.
a
Get me the
gentle
pigtail.
hand injection from with your hand. I think.
From my
Any
from my
pigtail.
sheath?
Five pigtail.
You are telling from the sheath tip side arm I can make an angio?
Enough. Put this
I'll
wire
do that.
inside. Put the wire inside.
If you do that angiogram, and then can we try and get you moving with the device, please, so we can get on to the debate?
Yes, wait on.
Okay.
Wire inside.
I mean,
This is a catheter like a sheath angiogram. I will get the LV angiogram. Angio ready? Syringe.
Yeah, injector is ready. Come with injector.
Yeah,
you're quite close to the wall there, aren't you?
I tend to do an angiogram with the TOE probe pulled back.
Yeah, Srija.
I can't see anything.
Yeah. So can we get the angiogram ready? We want about 20 ml at 15 rate.
Let's check the
2015.
yeah, it's out.
Yeah.
Come more cranial. Little bit of cranial.
You are ready for the injection? 20 ml, 15 rate, around 1000 psi. Ready? Is it the same view that we originally started?
No,
Give
cranial, more
cranial.
cranial.
Yeah, give cranial.
30 cranial.
The ECG is now stable. Probably it is. It's not touching the left ventricle now. Left ventricular wall. Yeah, go cranial. I wanted to show the device as well.
It's here.
Yeah, Srija, correct, perfect.
Cranial.
Okay,
Come.
table up,
Table up.
table up, please. Yeah, that's good. Can we? 20 ml at 15 rate. In the meantime, let me show the device now. Show the device.
So we need to see your hands.
Yeah, can you
See
show the
the-
camera? Camera big?
Yeah.
Yeah.
That's it.
So,
Good.
so the device is more or less shaped like, okay, I will try to see, okay, okay. It is more or less shaped like a PDA device. It has got a narrow waist in the center and a right ventricular disc. This is an 8 mm device which has got a 16 mm LV disc and a 12 mm RV disc. It is a 6 French compatible system. Sorry, I think it's a 7 French compatible system, and we are loading it on a 7 and pushing through a 7.
Inject.
Ready? Okay. Shall I give a hand injection?
That's good.
Okay. This is a very soft injection from my hand. We are getting ready to sort out the injector. Ready?
Ready? Okay.
You obviously haven't had lunch yet, Shiva, have you? Hand injection is not very strong.
No. Okay. Ready, Mohammed?
Yes.
Okay. In the meantime, what we can do is we can keep the device at the tip of the sheath, so that the moment he injects, connected.
We are ready.
Tell me when you are ready. Yeah. Okay. Shoot. Okay. It looks like we may be through the inferior defect. Can you show? Can you freeze it?
Freeze. Freeze when it comes.
Free.
Does that
Yeah.
matter?
The previous. The next view. Next. Correct. Yeah. Just can you zoom this? Zoom that. Yeah. Move that. Yeah. It looks like the upper and lower orifice, and we may be through the lower orifice, but let me see how it opens out. So let it be on the same level of zoom, Mohammed.
Same zoom.
Same zoom. Srija, how is the device coming up?
Just
Can you?
pushing.
Sorry, your hand is getting exposed.
The helper from this side.
Yeah, can one of you
Okay,
manipulate?
No, it's okay. It's okay.
Yeah,
it's okay.
Srija, you
Just
take
leave
your
it. Yeah.
hands out, but Raghu, can you manipulate? Yeah.
Can we have picture?
Echo bigger. Take away the
It's
photo.
okay, I will
Yeah,
just
perfect. Yeah, so now, Srija, can you show it on a 40 degree? 40 degree. Yeah, make it picture a little brighter also. I'm going to pull back
Yeah,
now.
just
Yeah, perfect. Go inside a little bit towards the left ventricular outflow tract. Raghu, can you push it so that?
push in little bit, yeah.
Yeah.
No, not that much, little bit out. Yeah, that's fine.
So my side arm is connected to pressure as well. I am reading left ventricular pressure right now. I'm slowly withdrawing.
Warwick was just commenting that this device is really quite hard to see on fluoro, and I agree with him. I've never used it before, but
Okay. I will get it on a cine now so that it is seen a little better. Yeah, I agree that it is a little softer. Can you come to AP view?
Slowly.
Slowly.
Slowly. AP.
Yeah. While Srija is trying to show you the picture, I'll try to show you an AP. Oh, that is also hidden by the
Bang on
TE
the
probe. Yeah, little bit T probe out. I'll show the device once and then.
Even
Oh,
here
it's
it is not seen.
okay. Yeah, it's quite faint. Can we quickly go to LV angiogram?
Come for an LV angiogram.
Or Srija, you feel I will stop the fluoro. You can show the echo now.
Push it in.
Yeah, echo big, only echo. Only echo. Yeah, same ML.
Same ML.
You can go to start from 40 degree, 30 degrees, and then keep on viewing in all the views region. Here, color. Color the. Yeah. Keep on rotating and till.
Some AR.
I think some of the initial X-ray pictures was showing that this VSD was possibly
Some
little
residual
smaller,
flows
and that was the concern of Dr. Neil Wilson. However, I can tell, having seen the patient, it was little. It's not such a small VSD. It was a moderate-sized VSD with a significant amount of shunt.
Some residual
Short.
flows. And
Yeah,
What do you think?
some flows are there.
along
Short
the
axis.
anterior margin. Some AR.
You know, Shiva, I
Yeah.
mean, you can always actually cross this defect, the one that looks a little bit in the bottom edge of the device, and put another smaller device there.
Okay.
Because I don't think that one device is going to take care of this VSD.
Okay. Okay. Now color and show, Srija. Yeah. If the device is stable, I will release this device, and then you will be able to assess it even better, because the cable may be pushing the device inside the right ventricle.
Yeah, this flows. Residual flows.
You are ready?
Siva,
Yes.
we are
You are
quite-
ready for a
we
LV
are
angiogram?
Come for
Yeah.
LV.
One LV angiogram?
Move.
Fever.
Yes.
We are quite pressed for time.
Yeah.
So I'd like to go to the KOL competition
Sure,
within
sure.
the next minutes if possible. So I don't want to pressurize you too much, but if we can
Yeah.
get to a
Rotate
where-
the till you get yeah, a little bit more LAO, little bit more LAO, more LAO. Yeah. Okay. Get ready for one angio. Little bit more.
Siva,
Yes.
maybe could we come back to you if we go to the competition?
Sure.
Maybe we'll
Maybe
come back.
maybe after Dr. Neil or Shaq presents their first case, you can come back to us so that you know, we can show
That's
you
what
what.
we'll do.
Great.
Thank
Well
you very
done,
much,
well done.
Siva. Good job, guys.